Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Henoch-Schönlein Purpura, also known as immunoglobulin A vasculitis, designed for general pediatric physicians. We will work through evidence-based clinical cases covering the full scope of this condition, including clinical presentation in the classic tetrad, physical examination findings, underlying pathophysiology and immune mechanisms, diagnostic investigations and classification criteria, treatment strategies for both acute symptoms and severe nephritis, and important complications including gastrointestinal emergencies and renal outcomes. Let us begin. Case 1. A 6-year-old boy presents with a 3-day history of painful, red-purple spots on his legs and buttocks. The rash is non-blanching and palpable. He also complains of severe knee pain and abdominal discomfort. What is the most likely diagnosis? Option A, idiopathic thrombocytopenic purpura. Option B, Kawasaki disease. Option C, Henoch-Schönlein Purpura. Option D, scarlet fever. The correct answer is option C, Henoch-Schönlein Purpura. This condition is defined by a classic tetrad of 4 findings that are highly characteristic. First, palpable purpura occurring on dependent areas, particularly the legs and buttocks. Second, arthralgia or arthritis affecting especially the knees and ankles. Third, abdominal pain that is typically colicky and may include gastrointestinal bleeding. Fourth, renal involvement presenting as hematuria and proteinuria. The peak age of presentation is 4 to 6 years. The rash is characteristically non-blanching and symmetric, and the underlying histological process is leukocytoclastic vasculitis. Case 2. A 7-year-old girl presents with colicky abdominal pain, vomiting, and dark bloody stool. She had a sore throat 10 days ago. On examination, she has diffuse abdominal tenderness and palpable purpura on her lower extremities. Urinalysis shows microscopic hematuria. What is the most appropriate next step? Option A, immediate laparotomy. Option B, abdominal ultrasound. Option C, colonoscopy. Option D, start oral prednisolone. The correct answer is option B, abdominal ultrasound. Abdominal ultrasound is the first-line imaging modality for evaluating acute abdominal pain in patients with Henoch-Schönlein Purpura. It has several important advantages in this clinical context. It is non-invasive and does not involve radiation exposure. It is excellent for detecting intussusception, which occurs in up to 3% of cases. It can also identify bowel wall thickening and free fluid in the abdomen. It is immediately available in emergency settings and is superior to computed tomography for pediatric patients due to the absence of radiation. The preceding viral illness, in this case the sore throat, is a common trigger for Henoch-Schönlein Purpura. Gastrointestinal symptoms occur in 50 to 75% of all patients with this condition. Case 3. A 4-year-old girl presents with a 5-day history of red-purple spots on her legs and buttocks. The spots are raised and do not blanch with pressure. On physical examination, the lesions are symmetrical and predominantly affect the lower extremities. What is the most characteristic feature of a skin lesion in Henoch-Schönlein Purpura? Option A, petechiae. Option B, purpura. Option C, ecchymosis. Option D, vesicles. The correct answer is option B, purpura. Palpable purpura is the hallmark skin lesion of Henoch-Schönlein Purpura. These are raised, non-blanching, red-purple spots that result from vessel wall inflammation and blood leakage into the skin. They commonly appear on dependent areas such as the legs and buttocks and show a characteristic symmetrical distribution pattern. The underlying pathological process is leukocytoclastic vasculitis. 3 key features distinguish purpura from other skin lesions. Unlike petechiae, purpura and Henoch-Schönlein Purpura are palpable and raised. Unlike ecchymosis, purpura are smaller in size and multiple in number. Unlike vesicles, purpura are solid lesions and not fluid-filled. Case 4. A 6-year-old boy with Henoch-Schönlein Purpura has bilateral knee swelling and pain for 2 days. On physical examination, the knees are swollen but not warm or red. Range of motion is limited due to pain, and no joint effusion is detected. What is the most likely explanation for these findings? Option A, septic arthritis. Option B, hemarthrosis. Option C, vasculitic arthritis. Option D, osteomyelitis. The correct answer is option C, vasculitic arthritis. Joint involvement in Henoch-Schönlein Purpura affects 60 to 80% of patients and presents as vasculitic arthritis with a very characteristic appearance. The key distinguishing feature is periarticular swelling that occurs without significant warmth, redness, or joint effusion. This non-inflammatory external appearance despite internal inflammation is what separates it from septic arthritis. For additional features, define the joint involvement in this condition. It predominantly affects large joints, particularly the knees and ankles. The swelling is due to immune complex deposition in the vessels of the joint capsule. Importantly, there is no joint destruction, and there are no long-term joint complications or residual damage. Case 5. A 6-year-old boy with Henoch-Schönlein Purpura has elevated serum immunoglobulin A and abnormal immunoglobulin A glycosylation detected on laboratory analysis. His mother asks about the underlying cause of his condition. What is the key immunological abnormality in the pathogenesis of Henoch-Schönlein Purpura? Option A. Immunoglobulin G-mediated immune complex deposition. Option B. Immunoglobulin M deficiency leading to impaired clearance. Option C. Galactose-deficient immunoglobulin A1 immune complexes. Option D. Anti-neutrophil cytoplasmic antibodies. The correct answer is option C. Galactose-deficient immunoglobulin A1 immune complexes. The pathophysiology of Henoch-Schönlein Purpura follows a well-defined sequence of immunological events. Under normal conditions, immunoglobulin A1 molecules have proper galactose glycosylation in their hinge region. In Henoch-Schönlein Purpura, however, aberrant glycosylation occurs, producing galactose-deficient immunoglobulin A1. These abnormal molecules become autoantigens that are recognized by circulating antibodies. The resulting pathogenic immune complexes deposit in the walls of small blood vessels. This triggers the inflammatory cascade that causes vasculitis in the skin, kidneys, and gastrointestinal tract. This mechanism also explains why Henoch-Schönlein Purpura so frequently follows respiratory infections, as increased immunoglobulin A production during infection drives aberrant glycosylation. Case 6. In Henoch-Schönlein Purpura, which complement pathway is most commonly activated by immunoglobulin immune complexes? Option A. Classical pathway. Option B. Alternative pathway. Option C. Lectin pathway. Option D. All three pathways. The correct answer is option D. All three pathways. Immunoglobulin A immune complexes in Henoch-Schönlein Purpura activate all three complement pathways: the classical pathway, the alternative pathway, and the lectin pathway. The deposition of galactose-deficient immunoglobulin A1 immune complexes in vessel walls triggers widespread complement activation across all three systems simultaneously. This activation leads to the generation of potent inflammatory mediators called anaphylatoxins, specifically complement components 3A and 5A, as well as the membrane attack complex. These mediators recruit large numbers of neutrophils to the vessel walls, resulting in the characteristic leukocytoclastic vasculitis that defines Henoch-Schönlein Purpura histologically. Case 7. A 5-year-old boy presents with palpable purpura on his legs and buttocks that developed over 3 days. He has severe knee and ankle pain and episodes of crampy abdominal pain with one episode of bloody stool. Urinalysis reveals microscopic hematuria and mild proteinuria. Physical examination confirms non-blanching, raised purple lesions predominantly on the lower extremities and buttocks. Which classification criteria are most accurate for diagnosing immunoglobulin A vasculitis, also known as Henoch-Schönlein Purpura, in children? Option A. 1990 American College of Rheumatology criteria. Option B. The 2010 European League Against Rheumatism, Pediatric Rheumatology International Trials Organization, and Pediatric Rheumatology European Society criteria. Option C. 2023 American College of Rheumatology and European League Against Rheumatism classification criteria. Option D. 2019 Single Hub and Access Point for Pediatric Rheumatology in Europe Consensus Criteria. The correct answer is Option B. The 2010 European League Against Rheumatism, Pediatric Rheumatology International Trials Organization, and Pediatric Rheumatology European Society criteria. These criteria have 100% sensitivity and 87% specificity in children for classifying immunoglobulin A vasculitis when distinguishing it from other forms of vasculitis. The criteria require one mandatory feature plus at least one additional criterion. The mandatory criterion is palpable purpura with lower limb predominance. The 4 additional criteria are diffuse acute onset abdominal pain, acute onset arthritis or arthralgia, kidney involvement shown by proteinuria or hematuria, and leukocytoclastic vasculitis with immunoglobulin A deposits on biopsy. Meeting the mandatory criterion plus any one of these 4 confirms the diagnosis. Case 8. A 5-year-old girl was diagnosed with Henoch-Schönlein Purpura 2 weeks ago after presenting with characteristic palpable purpura, joint pain, and mild abdominal symptoms. Her initial urinalysis showed trace proteinuria, but no hematuria. She has recovered well from her acute symptoms. Her parents ask about long-term follow-up. What is the most appropriate monitoring schedule for detecting potential renal complications? Option A, weekly blood pressure and urinalysis for 6 months. Option B, monthly complete blood count and electrolytes for 3 months. Option C, quarterly renal ultrasound for 2 years. Option D, annual creatinine and blood pressure check only. The correct answer is option A, weekly blood pressure and urinalysis for 6 months. Early and consistent monitoring is crucial for detecting Henoch-Schönlein Purpura nephritis, which can develop weeks to months after the initial presentation. The recommended approach is weekly monitoring for the first month, then monthly monitoring for 6 months. This schedule allows early detection of renal involvement when intervention is most effective. For key reasons support this monitoring protocol. Blood pressure monitoring detects hypertension, which is an early sign of nephritis. Urinalysis screens for the development of hematuria and proteinuria. Late-onset nephritis occurs in up to 15% of all cases, often appearing after the rash has resolved. Early detection significantly improves long-term renal outcomes. The critical point to communicate to families: nephritis can appear up to 6 months after initial symptoms, so consistent monitoring must continue even after the child appears fully recovered. Case 9. An 8-year-old girl with Henoch-Schönlein Purpura developed renal involvement 4 weeks after initial presentation. Current findings include blood pressure of 145 over 90 millimeters of mercury, urinalysis showing 3+ proteinuria and 2+ hematuria, urine protein to creatinine ratio of 350 milligrams per millimole, and serum creatinine of 95 micromoles per liter, which has doubled from a previous value of 45 micromoles per liter. There is no oliguria or edema. Which finding is the strongest indication for renal biopsy in this patient? Option A, elevated blood pressure above the 95th percentile. Option B, microscopic hematuria with proteinuria. Option C, doubling of baseline serum creatinine. Option D, nephrotic range proteinuria above 250 milligrams per millimole. The correct answer is option D, nephrotic range proteinuria. Nephrotic range proteinuria is the strongest single indication for renal biopsy in Henoch-Schönlein Purpura nephritis because it indicates severe glomerular involvement that requires tissue diagnosis to guide management. For key points, explain why biopsy is indicated here. First, the biopsy helps determine the extent of crescentic changes in the glomeruli. Second, histological findings directly guide the intensity of immunosuppressive therapy. Third, the characteristic finding on biopsy is immunoglobulin A deposition in the glomerular mesangium. Fourth, timing matters. Early biopsy performed within 3 to 6 months of onset provides better prognostic information. This patient should receive urgent nephrology consultation, and renal biopsy should be considered within 2 to 4 weeks of this presentation. Case 10. A 5-year-old boy diagnosed with Henoch-Schönlein Purpura presents to the emergency department with severe colicky abdominal pain, rated 8 out of 10, and bilateral knee pain that prevents him from walking. His parents report he has been crying inconsolably for the past 6 hours. On examination, he has typical palpable purpura on his lower extremities and buttocks, with moderate abdominal tenderness and bilateral knee swelling without warmth or erythema. What is the most effective treatment for providing symptomatic relief in this patient? Option A, oral prednisolone. Option B, intravenous morphine. Option C, ibuprofen. Option D, acetaminophen only. The correct answer is option A, oral prednisolone. Oral prednisolone at a dose of 1 to 2 milligrams per kilogram per day is the most effective treatment for symptomatic relief of severe abdominal pain and joint pain in Henoch-Schönlein Purpura. While corticosteroids significantly reduce the duration and severity of pain symptoms, it is essential to understand what they do not do. They do not prevent nephritis development and do not alter the overall disease course or outcome. 4 important clinical considerations apply when using corticosteroids for this condition. They should be started within the first week of symptoms for the best effect. They do not prevent the development of nephritis. Side effects must be monitored with prolonged use. For severe gastrointestinal bleeding, intravenous methylprednisolone should be considered instead. The treatment duration is typically 2 to 4 weeks with gradual tapering. Case 11. A 5-year-old girl develops Henoch-Schönlein Purpura with typical palpable purpura on her legs and mild joint pain. Her parents are concerned about kidney problems and ask whether starting steroids immediately will prevent her from developing kidney disease later. Physical examination shows classic non-blanching purpura on the lower extremities. Initial urinalysis is completely normal, and there is no abdominal pain or gastrointestinal symptoms. What is the most accurate statement regarding early steroid therapy and renal prevention in Henoch-Schönlein Purpura? Option A. Early steroids significantly reduce the risk of nephritis. Option B. Steroids do not prevent renal disease. Option C. Steroids should be started in all patients with Henoch-Schönlein Purpura. Option D. Steroid timing determines renal outcome. The correct answer is option B. Steroids do not prevent renal disease. This is one of the most important evidence-based conclusions in the management of Henoch-Schönlein Purpura, supported by multiple high-quality clinical trials. 3 landmark studies reached the same conclusion. Ronkainen and colleagues in 2006 showed that early prednisolone did not reduce the incidence of nephritis. Huber and colleagues in 2004 found no difference in renal outcomes at 1-year follow-up between treated and untreated groups. Weiss and colleagues in 2007 confirmed that steroids are effective for symptom relief but not for renal protection. The evidence-based recommendations are therefore clear. Use steroids for severe abdominal pain and joint symptoms. Do not prescribe steroids solely for renal protection. Focus on long-term monitoring for early nephritis detection, and consider angiotensin-converting enzyme inhibitors for established proteinuria. Case 12. An 8-year-old girl with Henoch-Schönlein Purpura develops acute kidney injury with creatinine rising from 0.6 to 2.1 milligrams per deciliter over 5 days. Urinalysis shows 4+ proteinuria, 3+ hematuria, and red cell casts. Renal biopsy reveals crescentic glomerulonephritis with more than 50% crescents. Blood pressure is 145/95 millimeters of mercury. What is the most appropriate initial treatment for this patient? Option A. Oral prednisolone 1 milligram per kilogram per day. Option B. Angiotensin-converting enzyme inhibitor therapy alone. Option C. Methylprednisolone pulse therapy combined with cyclophosphamide. Option D. Supportive care with fluid restriction. The correct answer is option C. Methylprednisolone pulse therapy combined with cyclophosphamide. Severe Henoch-Schönlein Purpura nephritis with crescentic glomerulonephritis is a nephrology emergency requiring immediate and aggressive immunosuppression. The rationale for this combination therapy rests on 4 key points. Methylprednisolone pulse therapy at 30 milligrams per kilogram per day for 3 consecutive days provides a rapid and powerful anti-inflammatory effect to halt the immune-mediated destruction. Cyclophosphamide at 2 milligrams per kilogram per day targets B-cell proliferation and autoantibody production. Together, they work synergistically to suppress the immune response from multiple pathways. Early aggressive treatment is critical to prevent irreversible renal scarring. This approach is supported by Kidney Disease Improving Global Outcomes Guidelines, which recommend aggressive therapy for crescentic nephritis, and studies show improved long-term renal outcomes with early intervention. Case 13. A 5-year-old girl with confirmed Henoch-Schönlein Purpura presents to the emergency department with sudden onset of severe cramping abdominal pain and vomiting. She developed the characteristic purpuric rash on her legs 4 days ago. On examination, she appears distressed, has a palpable abdominal mass in the right upper quadrant, and shows signs of dehydration. Her parents report she has not passed stool in the last 12 hours. What is the most likely gastrointestinal complication requiring urgent intervention? Option A. Gastrointestinal bleeding. Option B. Intussusception. Option C. Bowel perforation. Option D. Appendicitis. The correct answer is option B. Intussusception. Intussusception is the most serious gastrointestinal complication of Henoch-Schönlein Purpura, occurring in 2 to 5% of cases. Several features of this complication are clinically distinct from typical intussusception in infants. It is usually of the ilio-ileal type, unlike the typical ileocolic intussusception seen in infants. It results from submucosal hemorrhage and edema creating a lead point within the bowel wall. The classic presentation includes severe colicky pain, vomiting, and a palpable abdominal mass. It may present without the classic current jelly stools. Immediate recognition is essential to prevent bowel ischemia. Management depends on clinical stability. Non-surgical management includes hydrostatic reduction and close monitoring. Surgical intervention is indicated for bowel perforation, peritonitis, failed reduction attempts, or signs of ischemia. Case 14. A 7-year-old girl was diagnosed with Henoch-Schönlein Purpura 6 months ago after presenting with typical palpable purpura, arthralgia, and mild abdominal pain. Her acute symptoms resolved within 2 weeks with supportive care. At her 6-month follow-up visit, she remains asymptomatic with no visible rash or joint complaints. However, laboratory studies show ongoing urinary abnormalities. What finding is the most significant predictor of long-term chronic kidney disease in this patient? Option A, age at initial Henoch-Schönlein Purpura diagnosis. Option B, duration of the original purpuric rash. Option C, presence of abdominal pain during the acute phase. Option D, persistent proteinuria at 6 months. The correct answer is option D, persistent proteinuria at 6 months. Persistent proteinuria beyond 3 months is the single strongest predictor of chronic kidney disease in children who have had Henoch-Schönlein purpura nephritis. A urine protein to creatinine ratio greater than 100 milligrams per millimole indicates high risk for progressive renal disease. Early identification of this pattern enables targeted monitoring and intervention before irreversible damage occurs. Other risk factors for poor renal outcome include a severe initial presentation and older age at onset of the condition. The clinical pearl to apply in practice. Monitor all patients with Henoch-Schönlein purpura with urinalysis monthly for the first 6 months, then quarterly for 2 years, regardless of whether the acute symptoms have fully resolved. This ongoing surveillance is the most powerful tool available for protecting long-term renal function. Before we close, we want to share an important resource with you. The Pediatric Case Review community on Patreon gives you access to a comprehensive, system-organized clinical education library. All videos are arranged by medical system, so you can find exactly what you need in one convenient location. You also get downloadable presentation slides in high-resolution format for offline study, as well as practice questions designed for self-assessment and board exam preparation. If you would like to join and get the subscription details, simply comment below this post, and our team will message you directly with everything you need to get started. And that brings us to the end of today's comprehensive case-based review of Henoch-Schönlein purpura. Over the course of this lecture, we explored this condition through evidence-based cases covering 5 core domains: clinical presentation in the classic tetrad of purpura, arthralgia, abdominal pain, and renal involvement; pathophysiology, including the role of galactose-deficient immunoglobulin A1 and complement activation; diagnosis through classification criteria and appropriate investigations; treatment from first-line corticosteroids for symptom relief to aggressive pulse therapy for severe nephritis; and complications including intussusception and the predictors of chronic kidney disease. Please follow Pediatric Case Review for more comprehensive, case-based lectures on pediatric conditions. If you have questions about Henoch-Schönlein purpura or any other pediatric topic, comment below and we will be happy to help. Stay curious, stay clinical, and keep learning.